Hello, everyone, and welcome to this webinar on public policy and health in the USA, looking specifically at affirmative action and racial health justice. I am Miriam Sabin, the North American Executive Editor for the Lancet. I'm based in New York City, and we are very privileged to present this webinar in partnership with the UCLA David Geffen School of Medicine, the Cambridge Health Justice Lab, the Cambridge Health Alliance, Roosevelt House at Hunter College, and Harvard Medical School. I want to just go through a few housekeeping tips for us first before we get started. So just to say that attendees are welcome to submit questions throughout the presentation. Use the Ask a Question box on the dashboard. On the webinar dashboard, you will see a box with related resources. A link to related Lancet content is featured and will take you to thelancet.com. You can adjust or minimize any of the boxes that appear on the webinar dashboard to suit your preferences. And a link to the on-demand version will be emailed to all once the webinar has concluded. Just a content warning also before we start that some of the images and language in this webinar may contain potentially distressing material for some participants. And now with that, I'd like to hand over to the chair of this webinar, Michael Mensa. Michael, over to you.
Thank you, Editor Babin, for the kind introduction. My name is Dr. Michael Mensa, and I'm a psychiatrist, national clinician scholar, and PhD candidate at Yale University. And I'm honored to chair this discussion on affirmative action and racial health justice. The US Supreme Court will likely outlaw racial considerations in university admissions this spring. How might this affect health and healthcare in the United States? This webinar will assess the likely effects of the forthcoming Supreme Court decision on racial health disparities, as well as racial diversity in the health professions. We have three esteemed speakers comprising our panel today, who I will introduce in order of appearance. Speaking first is Dana Bowen Matthew, JD, PhD, the Dean and Harold H. Green Professor of Law at the George Washington University Law School, a leader in public health and civil rights law who focuses on disparities in health, healthcare, and the social determinants of health. Dean Matthew joined GW Law in 2020. She also is the founder and inaugural faculty director of GW's newly chartered Equity Institute, an interdisciplinary research hub dedicated to addressing racial, ethnic, and socioeconomic injustice. A prolific writer, Dean Matthew is the author of two best-selling books, Just Medicine, A Cure for Racial Inequality in American Healthcare, and the recently released Just Health, Treating Structural Racism to Heal America. She's the co-author of a casebook on public health, law, ethics, and policy. Speaking second will be Professor Marcella Alsan, MD, PhD, an infectious disease physician and professor of public policy at Harvard Kennedy School. She is an applied microeconomist studying health inequality. She was elected to the National Academy of Medicine and was awarded a MacArthur Fellowship in 2021. Speaking third will be Professor Michelle Morse, the inaugural Chief Medical Officer and Deputy Commissioner for the Center for Health Equity and Community Wellness at the New York Department of Health and Mental Hygiene. She is also assistant professor at Harvard Medical School, co-founder of Equal Health and Social Medicine Consortium. Dr. Michelle Morse is an internal medicine and public health doctor who works to achieve health equity through global solidarity, social medicine, anti-racism education, and activism. Now we'll have Dean Bowen Matthew provide her insights on the issue from a legal perspective. Professor Matthew, thank you for joining us. Your book, I read through it, it's amazing, and I'm eager to hear your insights.
Well, thank you so much. It's such a privilege, Dr. Mensa. I just commend you for the courage of inviting a lawyer, and not just a lawyer, but a lawyer in constitutional law, to bring the very current issues of affirmative action and its pending demise to the medical audience. I'm so grateful for this chance to talk to the webinar audience, but I will tell you, I have a lot of slides to run through, so I'm going to speak rather quickly. Let me just begin by saying that I have one message and one message only, and that is that health is a byproduct of justice. You will know how healthy your populations are and how healthy a society we are by how just our society is. They are integrally related, and I'd like to prove that to you. That is to say that in order to achieve health equity, we have to achieve justice. On the right, you see that we have to eliminate unjust, unfair, and avoidable disparities in all of the social determinants of health if we truly want to have an equitable society that is characterized by health equity. Why is that? I want to leave this word picture with you quickly in order to begin the conversation about health justice. First and foremost, we are a society that is divided into the haves and the have-nots, perhaps worse than any society if we look by the Gini index, which is used by the World Bank to describe the difference between the top quintile earners and the lowest quintile earners. Our best research, for example, research by Pickett and Wilkinson, tell us that this plane tells a story. This is the plane, Flight 1549, that landed on the Hudson River in January of 2009. In that accident, the 155 souls on board came out for rescue in the chilly, frigid waters of the Hudson River. Their life chances outside of the plane were described by whether they were in the large group on the back of the plane's wing or in the small group in the front of the plane in life rafts. At the time of this accident, most people in coach had no life rafts, had no food rations, had no things to wave down a signal for help. If they stayed out there, their life chances were far worse than those in the front of the plane in first class, who had all of the provisions that would allow them, for example, to not eat each other as soon as the others would because they had little boxes of food. I say that with only a little bit of humor because that is a word picture for the fact that place matters in the United States. Where you are born, where you are sitting on the plane makes a difference in your life chances. And so I go on to say that you will see this in the lives of individual patients that you treat. Let me introduce you to my parents, who are an exemplar of the structural inequality that I've described with the plane in the prior slide, but they will give you a racialized view of that structural inequality. My parents are African American, and they were in this picture ages 46 and 47. However, because we lived in the South Bronx, a neighborhood that was characterized by low wages, substandard education, residential segregation by race meant also increased exposure to pollution, whether it was highways, trash waste stations, or other sources of pollution. We were exposed to neighborhood violence on a disproportionate basis, and environmental toxins, the food we ate, etc., the air we breathed, the water we drank was different because of our race. This racialized version of structural inequality led to my father's early death. In fact, 1 year after this picture was taken, at age 48, he was dead. I posit that he was not dead because of obesity. Yes, he's slightly overweight, or high blood pressure. He had those. He was dead because he had a dream to get me out of the South Bronx from Public School 93, the school that I attended until 4th grade, and that all of my peers in that racially segregated neighborhood attended, to a school in the bucolic Bronx section of Bronx called Riverdale, New York. Now, this is only 7 miles from my home, but you can see appreciably that my life chances improve remarkably if I am not going to PS 93, but instead going to the Ethical Culture Fieldston School 7 miles away. The grass is greener on the other side. So is the food better, the air cleaner, the water clearer. So are the housing options more decent, and the wages that my father could earn had he been born in Riverdale instead of the Bronx. Now, why was he dead at age 48? Well, in order to get me to Fieldston, he had to work 2 full-time jobs and 2 part-time jobs. In the morning, he would go down to the Bowery Savings Bank, where he was a real estate lender, and he'd work 8 hours, proudly walking back to our home to eat dinner, go to sleep, and wake up and ride the same subway. But this time, instead of riding it down to the bank where he was going to work as a banker, he drove it as a member of the New York City Transit Authority. So an 8-hour shift from midnight to 7, a couple of hours sleep, and then 9 o'clock in the morning back at it at his desk. That plus 2 superintendent jobs will send one to an early grave. If it were not the case that my father's case is unremarkable from the standpoint of how many of our racial and economic backgrounds share this story, I couldn't tell it as a structural problem, but it is a structural problem. It is the fact that my father had to get access to education, housing, food, and other opportunities outside of the racially segregated area that we lived in. Let me focus on education because that's really what drove my father to work 2 jobs full-time and 2 jobs part-time, and my mother to work 2 part-time jobs. They wanted to overcome the structural deficit that attended those living in our neighborhood with respect to education. So this is what educational discrimination used to look like. This was pre-Brown versus Board of Education, and these are the ugly scenes that we know from history. But let me tell you that the connection between educational attainment and health make the new form of racial discrimination in education extremely important. Now, we can come back to this in the Q&A if you'd like, but there are 3 pathways: psychosocial, through the work that is available to you as a result of your educational attainment, and through your health literacy and knowledge that educational attainment is causally, not just correlational, but causally linked to health outcomes. This is a study by Hogue et al., and we could talk about it in detail, but let me share with you the very clear indication that if you graduate from high school in the United States of America, your life expectancy increases markedly. This is shown by the risk of death at progressive levels on this scale for non-Hispanic whites, Blacks, males, and females. So we know that there is a connection between the social determinant of health, that is educational attainment, and we know that it is an association that is disparately a determinant. Education is a determinant that is disparately distributed across our population by race. How does poor education contribute to poor health? I'll show you 3 ways: through resource disparities, discipline disparities, and the school to prison pipeline. Let me suggest at the outset that all 3 of these contributing factors are disproportionately distributed by race. That is to say that Black, Latino, Native American, and several Asian populations bear a disproportionate burden of having been, well, let me use the analogy I used in the beginning of my talk, having been on the wrong seat in the plane. All right, so let's look at these. By race, white students get more funding than African American and Latino students, Native American, and most Asian students than those that are white in the United States, to the tune of a $23 billion gap as of 2019. This means that the schools that my parents worked hard, in fact, worked to their death to get me out of, are schools that don't have after-school band programs, that don't have art programs, that don't have IB programs, international baccalaureate programs. They have less skilled teachers. They don't have a full set of courses that are preparatory for college. The courses for science and STEAM that are distributed by race and ethnicity, as this chart shows, are more available to white students in the United States than they are to African American, Latino students, and Native American students. Moreover, we see disciplinary disparities in our schools. That is, preschool students at age 3 are more likely to be suspended or expelled from school starting in preschool 2.5 times more frequently than white students are if they're Black, Latino, or Native. What can we do about this? Well, you might say there ought to be a law. It turns out there is a law. The Civil Rights Act of 1964 included Title VI, here the signing ceremony, and Title VI simply says that no person in the United States can be discriminated against on the ground of race, color, national origin, or be excluded from the benefits of what a public institution provides on the basis of race. So why isn't that law doing the trick? Why aren't we able to distribute all of the social determinants of health? I've concentrated here on education, but housing, food, access to clean air because of your distance from pollution, all of the social determinants of health should be covered by that law. Shouldn't they? But they aren't. Why? Because over the course of time, this law has been weakened and chipped away at. Let's start with 2001, Alexander v. Sandoval. That's a case in which the Supreme Court decided that that law could only be enforced by administrative agencies, by companies like agencies like the EPA suing. They took away the right for individuals like Linda Brown, who got us Brown versus Board of Education, to sue under that law. That made it less powerful. Then, with respect to education, the Supreme Court decided in 2003 a case called Grutter versus Bollinger. And you've heard of this case, where the court said affirmative action can proceed, but it has to be very narrowly tailored. We can't use numbers. You can use a plus factor as of 2003, but the law has to be clearly this option has to be clearly the only one that can achieve the educational benefit of the term diversity. So that was a further narrowing of the 14th Amendment and the Title VI Civil Rights Act. Then again in 2016, affirmative action was tested in the Fisher versus Fisher versus University of Texas at Austin case, and that narrow tailoring became even more narrow. There was a requirement that the plan, if it was going to be race conscious, to admit people into a school like Texas, University of Texas, had to be the only necessary option available. There was careful judicial inquiry as to whether you could find a way not to achieve diversity by thinking of race as an explicit factor in admissions. This was a further narrowing, but not the only one, as we heard Dr. Mensah say in the introduction. Currently, the Supreme Court is considering decisions in two companion cases called Students for Fair Admissions versus first the University of North Carolina and Harvard University, a public and a private university. These are two landmark suits that Dr. Mensah quite correctly said are widely expected to end race consciousness in admissions. We know that that will be the defining characteristic of structural racism with respect to education. Now, I see that my time is just about up, so I will just very quickly run through the fact that this structural inequity that I talked about earlier, that connects the Gini index, which you just saw on that green set of bar charts, to social outcomes, right? So structural inequality means that in nations, those with the greatest difference between income inequality will have the worst outcomes by health and by social outcomes. That's the y-axis. We see that the United States has the greatest distance between the haves and the have-nots and the worst health outcomes. We saw that in COVID's distribution by race and ethnicity. We saw that being seated on the wrong seat in the plane made it possible for this virus to infect disproportionately those disadvantaged groups that are shown here. So structural racism, I'll close by saying, is defined as a system, not an individual prejudice, but a system that affected my parents' ability to get me an education, that affected the place we sat on the plane by ordering us hierarchically based on our race and then deciding what benefits we got based on our race. My closing message to you is that the changes in the law with respect to affirmative action are about to be a part of that same structural discrimination. For For that reason, I would suggest that we're no longer just selling people by the pound. We're no longer throwing them overboard as we did historically as property to lighten the load on a ship while they're alive. Well, that is not what structural racism looks like today. Instead, it looks like the denial of human rights, like access to water. It looks like disproportionate exposure to police enforcement. On the left, if you're white, you use marijuana at the same rate as those who are Black. On the right, however, you'll be arrested at a much greater rate if you're Black than if you're white for the same crime. What are the solutions? We have to fix the law. We have to march, as physicians did, in order to get Title VI of the Civil Rights Act. So advocacy is an important part of the solution. We have to litigate. The way we got Title VI was the landmark case of Simpkins v. Cone. That was a case in which two physicians, two dentists, and patients sued in order to desegregate 7,000 hospitals in the United States of America. And we have to vote. We have to vote in a way that reflects the social determinants of health and how they're distributed, because our health does depend upon it. The word reparations is also one that I hope we'll discuss in the Q&A, because the act of making amends to someone or some group of people that were discriminated against systemically is one that we should do some thinking about together. This is my last slide, and I use it to show that although this stand of redwood trees looks like a strong, individualized set of plants, they are in fact not. Each tree does not stand on its own. It is connected underground by a network of roots that is a picture of how we in the United States of America must attack health injustice, particularly the attack on affirmative action and the lack of educational attainment for those who are discriminated against in our society. I'll end there and pass the microphone to the next speaker.
Dean Bo Matthew, that was an amazing presentation. It makes me want to stop being a doctor and go to law school. It was really energetic, and a lot of insights, weaving in different disciplinary expertise and data, and I'm really excited. Thank you so much for that. We'll now move to Professor Marcella Alsan, who will evidence the value of provider diversity in healthcare.
So much, Dr. Mensa. Thank you. It was extraordinary, and thank you to Lancet for organizing us all. I'll talk to you one particular study, which is entitled "Does Diversity Matter for Health? Experimental Evidence from Oakland." And this was joint work with Dr. Owen Garrick, who is actually from Oakland, and Grant Graziani, who is a graduate student, as well as many other students who made this work possible, and of course, patients and doctors as well. Starting point, actually thinking about some of the disparities that Dean Matthew mentioned, in particular her father's story, as well as some prior work I had done documenting the causal effect of the Tuskegee disclosure event on the health, and thinking about what leading medical institutions were saying about how to remedy racial health disparities. Many of the most institutions in the United States were recommending that we did need to diversify our physician workforce. That was the #1 recommendation to addressing racial inequality, health inequality, from the Association of American Medical Colleges. But it was also echoed by the American Medical Association and the National Academies of Medicine. So we sought to interrogate this hypothesis using the most meaning we randomized control trial. We focused on Black men since, again, as mentioned by Dean Matthews with the parents, and in particular her father, Black men have one of the lowest life expectancies of any major demographic group in the US, was worsened with COVID-19. These deaths are preventable due to things like cancer and preventive is relatively, that's for many, health insurance is tied to employment in the United States, for instance, as well as some of the educational disparities that the dean was mentioning. And this trust is relatively mean compared to other groups, strictly meaning not helicopter sky, it's actually a response to institution and neglect. So we wanted to, again, interrogate the hypothesis whether greater diversity of physician workforce could indeed reduce racial health gaps. And in particular, since I'm an economist, I wanted to see whether with a race concordant would increase the demand for preventative health care. In order to do this, blind randomized at the individual level. So I'll just walk through those. Meeting both the physician for the experiment is not know that are true. In fact, to concordance mattered. The doctors were debriefed at the end, but the 14 doctors we hired knew that the goal was to take up of preventative care for Black men from Oakland. It was at the end, as you'll see in a moment, that for every patient that came in, we essentially flipped a digital coin, if you will, to determine their treatment assignment. And it was two-stage. In the first, the stage called the pre-consultation stage, where a subject was introduced to their randomly assigned doctor via a tablet, allowed to select preventative services via that tablet. A random set of subjects also receive a flu vaccination incentive, so a monetary incentive that was with the tablet photo. I actually met that doctor that they were randomly, they were able to interact and communicate with them in what we hoped was as natural patient-doctor encounter as possible. They could then revise their service selection and then receive those services specific from the assigned doctor. Doctors for this experiment are to work with a clinic in the Bay Area, but we really couldn't find a clinic, and this is no exaggeration, that employed one Black male doctor, much less a half dozen, which is what we at least needed for the study. So why did we have two stages? So the first stage was essentially, if you've seen on the news, maybe on NPR or Wall Street Journal, they'll talk about correspondence or audit studies. Back rates for Black sounding names or female names tend to be lower than for majority group or male names. That's essentially a test of Gary Becker's taste-based aversion. So essentially you're making snap judgments based on a preference. And so you just see a picture on a tablet, and then you decide, for example, that you prefer to have your this type of doctor versus this other type of doctor. It could also be, of course, internalized racism, which could go the other way, meaning that you would prefer to see, for example, the majority group. If, in fact, though, it's not about snap judgments, taste-based discrimination, or internalized racism per se, but if it's actually the magic, this thing today, that patient-doctor encounter, where you're able to exchange information more effectively or efficiently, if there is race concordance, then we wouldn't expect to see differences until that second stage. So in order to, and this was really important to us, we didn't want to use a convenient sample of people that were already in care. A lot of men in general, especially men who might not be as closely linked to the workforce, insurance or be underinsured. So it was Dr. Garrick's genius to actually recruit from barbershops in the area. We also use flea markets, but our primary place of recruitment were barbershops. These spaces where you can get a large cross-section of men, and they were able to answer surveys during the time that they were waiting for the haircuts, and then we were able to compensate them with free haircuts. Then they received survey to come meet again was we created. And we did try and some of the social actually having free rides that were given courtesy of Uber. So you have to kind of understand that the local adverse treatment effect that we're estimating is already getting around some of the key barriers to achieving equitable health care, namely insurance and of course transportation. Then once based on the tablet, either a non-Black doctor or a Black doctor, these were all male doctors that we hired, produced on the tablet. The tablet looked like faces here are grayed out. 14 physicians. We tried to harmonize all of the information. Again, the last name for this particular doctor is not shown, but we tried to. The doctor was licensed in them a list of services. None of the above was always an option, and we randomized the order. We offered blood pressure, weight and height, or BMI, cholesterol, and diabetes screening, and we noted that those required actually a finger prick of blood. And then on the next screen, if you had advanced it, would be the offer of a flu shot. So again, and they would see to choose which of any of these 5 preventative screenings they would like. Again, none of the above was always an option. Then they would interact with that doctor, that actual doctor in person, and then they would re-optimize, if you will, choose their preventative care, receive that care from the physician himself, and then provide us feedback. So, fine. So these just orientate you here. So is showing actually flu shot is a little bit more dramatic, but in the interest of it out of those slides for the time being. Pressure, BMI, diabetes, and cholesterol. And here you have the pre-consultation phase. That's in the first here, and also in the first row here. That's man that you would anticipate seeing, or that we measured actually seeing, just after the patient actually encountered the tablet, and then they did their selection. Let's just focus on these upper bars here. So we see that Black men who were recruited to our clinic that were assigned to a Black male doctor don't seem to have much difference in the blood pressure demand or the BMI demand. Those who were assigned to, which was this lighter gray bar. These bars, the average demand is similar across. If we move down to diabetes and cholesterol, again, we see these bars are not very different. The bars are in fact smaller, meaning that people are in general paying attention. Their registers actually require blood, and so their demand for these things is in fact lower, about 40%, of 60%, or BMI upwards of 50%. So in essence, we would say that in phase, there was no difference in take-up. So we don't find strong evidence for aversion or taste-based preference, or even this internalized. However, we differences in relation phase once the patients actually have a chance to interact. This is 24 versus a 16% increase in demand, 24 versus 10 percentage points, so a 24 percentage point jump versus a 10 percentage points jump, and for BMI. But where we really see things pull apart is for what we invasive. Now these are to take a little blood sample for diabetes or cholesterol tests, but they are actually pulling out. And so invasive, let's say, compared to just using a sphygmomanometer for something like blood pressure. And here we see again a 20 percentage point jump versus only a 5 percentage points jump for the patients that were as a non-Black doctor point jump versus only a percentage point jump patients that were paired with randomly as a non-Black doctor. Okay, so when we actually look at the mechanisms here, we see that were really, we had a couple hypotheses here, but it really came down to communication. We were able to kind of get the idea that it was quality, effort, or even discrimination. You have to remember that this was a very that was recruited to give up some of their Saturdays to run this clinic, and they all knew that they were trying to provide preventative services to Black men. So there was some selection on really good doctors in that regard. And talk about that more, but essentially the evidence suggests most likely better communication, which is driving. Respondents were 10 more likely to talk to the white physicians. Notes of the Black doctors were 11 characters longer. Our results accorded with a lot of non-experimental studies that we also brought to bear, including using data from the MAPS or our own survey that we ran that said that people felt like they were understood and that their doctor listened to them more. So in conclusion, as to Black male doctors increase the sake of preventative care, our results suggest the mechanism are more during the doctor-patient, and our findings would suggest increase the supply of Black doctors could help narrow
Thank you, Professor Alsana. That was amazing. Especially struck by your design that engaged with the Oakland community, leading to rigorous, impactful outcomes. Now we'll have Professor Michelle Morse provide her prescription for diversity in healthcare. Professor Morse.
Good afternoon, everyone. I hope you can hear me okay. It's really an honor to be with you this afternoon and to speak a little bit about some of the work I've had the pleasure of being a part of over the past 7 or 8 years in particular. And it's really about solutions to the racial inequities that we see in healthcare, and solutions that center reparations, reparative justice, restorative justice, and those kinds of approaches. And I think it really builds on what Dean Matthews and Professor Alston have described. Dean Matthews in particular, I was so thankful for your mention of Title VI of the Civil Rights Act, of course, and the legal framework that offers for healthcare-related racism. I also want to thank Professor Alston for the rigorous research demonstrating the power of racial and ethnic concordance, but also highlighting how unreal it is that we have so few doctors of color, and particularly Black doctors, in 2023, right? I mean, 70 years since the Civil Rights Act. So with that in mind, let me just jump into some of the reflections I wanted to share, and I'll be quite brief. I just have a few slides. I am really looking forward to the discussion as well. So if you can move to the next slide, please. So I want to start by just sharing the story of work that I had the honor of being a part of in partnership with many people at Brigham and Women's Hospital, but especially Dr. Bram Wispelwey, who's been a partner in this work over many years. What we set out to do in 2016 at Brigham and Women's Hospital was specifically to demonstrate examples of institutional racism in healthcare within our walls and develop solutions to actually ending those inequities. And a part of the reason that the work was possible at that time in 2016 and coming forward was really because of the incredible work and sacrifices of activists on the front line of the Black Lives Matter movement across this country and around the world, who were demanding change and demanding justice in ways that seeped into healthcare spaces like Brigham and Women's Hospital, and really created a window of opportunity for significant internal and external work around the hospital's mission, around achieving health equity as well. And at that time, residents and students across Harvard Medical School and Brigham and Women's Hospital were just truly pushing leadership, pushing faculty, pushing in every space possible for the institution to ask better questions and to do better on delivering equitable care. And one of the results of that push and that organizing and leadership from trainees and students across the institution was the development of a committee on health equity, which I had the honor of co-chairing within the Department of Medicine. And one of the things that we did was we joined Institute for Healthcare Improvement's network pursuing equity. We were in the first cohort. And one of the questions that students were asking and trainees and residents were asking is, why do we seem to see more white patients on the cardiology service when they come to the hospital with heart failure and more Black and brown patients on the general medicine service? Now, I myself have been a hospitalist on the general medicine service since 2012, and also, of course, was aware of these challenges, but it was incredible to see the mobilization of residents around this particular observation and a willingness and an interest to actually study it and figure out if that observation was backed up by the data. So that's what you see on this particular image. This was a publication that had numerous authors because of the huge amount of organizing work that happened and the number of people involved at the institution. And what we were able to do with leadership also from Dr. Eldrin Lewis, one of the only Black male cardiologists at the whole institution, was we looked at 10 years of data, over 3,000 individual patients, and were able to look also at comorbidities. We were able to look at insurance. We were able to look at a number of variables. And what we found in this study, unfortunately, was that Black and Hispanic patients were systematically less likely to be admitted to the cardiology service when they came to the emergency department with heart failure as their primary diagnosis. So specifically, about 2/3 of white patients who came in with heart failure ended up on the cardiology service. Only about half of patients who are Black or Latinx ended up on the cardiology service. So, again, with more of them ending up on the general medicine service. And part of the reason this mattered is, as many of you know, the Centers for Medicare and Medicaid Services were looking at readmission rates for heart failure as a quality outcome, and readmission rates for Black and Latinx patients have been higher. And in fact, what we found is on the cardiology service, the readmission rates for heart failure for Black and Latinx patients were the same as white patients. There were no significant racial inequities. And so we also posited that part of the reason for the differences in readmission rates by race ethnicity was because more white patients were on the cardiology service, which had more intensive nurse practitioner follow-up, more intensive medication management, and then, of course, having cardiologists at the lead of the care. And what we also found was that not only were Black and Latinx patients less likely to go to the cardiology service, they were also less likely to follow up in cardiology clinic after discharge. So this is an example of institutional racism, right? Institutional racism is essentially a lack of access to resources or a systematic exclusion from resources by race and ethnicity. And that's what was happening in this particular instance and was proven by rigorous research analytics looking at heart failure in multiple different ways across our institution. So what we had to reckon with was that in Brigham and Women's is a hospital that is world-renowned for the quality of its care. And yet we were dealing with a very clear example of institutional racism in heart failure care at our hospital. And what we needed to do, of course, was not only understand the drivers of this example of institutional racism, but we also needed to understand what the solutions would be. What we didn't want to do was wait another 10 years to implement solutions, right? We wanted to get directly into action as quickly as possible. So on the next slide, what you'll see is we actually developed a framework for action. And the reason that this is important for a number of reasons, but what we really wanted to do was to actually propose solutions that got at the core of the problem. And one of the things that we also researched was we surveyed emergency medicine providers at our ED at Brigham and Women's. And what we found was that they told us how, the things that were influencing their decision about where to send their patients, to cardiology or to the general medicine service. What they told us was actually that the patients, the white patients in the emergency department were systematically more likely to advocate for themselves to go to the cardiology service, and that advocacy actually influenced the decision of the emergency room provider on where to send the patient. So it's another example of the mechanisms by which institutional racism plays out and the mechanisms by which white privilege becomes operationalized and leads to institutional inequities like the ones that we found. So what we decided and what we said, with, again, lots and lots of conversation, I was a small part of this work, but I'm so amazed by what has been possible since this study happened. Dr. Wispelwey and I developed the perspective piece on the left, an anti-racist agenda for medicine. And what we describe in this piece, which was published in the Boston Review in March of 2021, we describe not only this history of our work on heart failure, but we also describe extensively how powerful the work of Sandy Darity and Kirsten Mullen on reparations has been for us. And what we developed was a framework that borrows from the steps that Sandy Darity and Kirsten Mullen describe around reparations being cash payments from the federal government to Black Americans who are descendants of enslaved people in the US. They describe 3 steps: acknowledgement, redress, and closure. And so we said, well, we need federal reparations to be paid to Black American descendants of slaves. And at the same time, even if that happened today, we would still have institutional racism at Brigham and Women's Hospital. And in fact, what we need to do is, in partnership, in addition to reparations, we need remedies for institutional racism in healthcare that would be paired with these other forms of reparations. And so we developed a framework called the Healing Arc. And the Healing Arc essentially is applying that framework to healthcare, to institutional racism in healthcare. And what we suggest in the Healing Arc is that acknowledgement be the starting point, acknowledgement of the inequities and the examples of racism, redress to change and end that inequity, and then closure being the community that has been marginalized or excluded from healthcare or harmed by healthcare actually have oversight over when it is determined that the harm has been remedied. And what we developed to address the heart failure inequities I just described at Brigham and Women's is actually a best practice alert in our electronic medical record system. We just were able to publish this article in the New England Journal Catalyst last year. And the best practice alert essentially says, if a Black or Latinx patient comes into the emergency room with heart failure, and the emergency clinician sends the patient to the general medicine service, a best practice alert comes up in the electronic medical record and says, this patient is from a racial or ethnic group that has been historically excluded from cardiology. Change the admission location unless there is some overriding reason not to. So this is an example, again, of also how we can use technology to address racial inequities. And we're going to have results of that study coming out in the near future, showing what the impact of that best practice alert was on the rates of Black and Latinx patients being sent to the to the cardiology service as opposed to the general medicine service. And my next and final slide really just gives you the specific language on that best practice alert. Again, this is an example of ways to leverage technology to address institutional racism. Results will be forthcoming. Now, the last thing I want to say in closing is really just that this work does not come without a cost. And unfortunately, what happened at Brigham and Women's Hospital was after publication of our article in the Boston Review, An Anti-Racist Agenda for Medicine, we received extensive threats on social media, text messages, phone calls, emails, personally to Dr. Wispelwey and I. Our institution actually also received a number of phone calls, letters. There was a network of white supremacists who jammed up the information line of the hospital, all under the guise of Brigham and us, Dr. Wispelwey and I, being racist against white people. And we know, of course, that that is not what was happening. What these networks of neo-Nazis and white supremacists were trying to do was to change history. And in fact, the real problem, as I just described extensively in the research that we've conducted, is that Black and Latinx patients are systematically excluded. That is the problem, period. In fact, what is pretty clear is that Brigham has to fix this in order to address Title VI of the Civil Rights Act, to ensure that there is equitable access to the cardiology service for all racial and ethnic groups. Now, unfortunately, this backlash against this work accelerated, and in January and February of last year, white supremacist neo-Nazi groups actually held 2 marches on the lawn of Brigham and Women's Hospital with pictures of Dr. Wispelwey and I on their flyers, and with banners saying that Brigham and Women's is racist against white people. So I think it's more important than ever that we take a clear stance as a health justice community on the fact that race-conscious solutions to racial health inequities must be implemented, and that we all need to be organizing, planning, and learning around what we should be doing to prepare for this upcoming Supreme Court decision on affirmative action, and how it may or may not apply to racial health inequities and examples of institutional racism, like we uncovered in heart failure care at Brigham and Women's Hospital. So I'm excited to have more conversations, hopefully with Dean Matthew and Professor Alston and Dr. Mensah offline as we get ready for the upcoming decision. And I feel more strongly than ever that it is race-conscious solutions to racial health inequities that are going to ensure that 20 years from now, right, we're 20 years from the publication of Unequal Treatment, the Institute of Medicine report or National Academy of Medicine report, 20 years from now, I do not want to be having the same conversation. And I know that race-conscious solutions are going to be one of the many pathways that get us to racial justice and health equity. Thank you so much.
Thank you, Professor Morris. That was fantastic, especially your emphasis that reparations and repair is not reverse racism. I think that's a very important point that we should emphasize. Now, we do have a bit of time for some questions, about 4 minutes. So I'm going to combine 2 questions for the sake of efficiency and ask each of you, if you're able, to state one. If you could have each of the viewers on this session do one thing to support racial equity in healthcare, what would you have them do? I'll start off with Dean Bowen Matthew, if you don't mind.
I would have the medical profession form another active committee for civil rights. The Medical Committee for Civil Rights was instrumental in making sure that we had a Title VI, in making sure that the role of physicians, clinicians, providers of healthcare didn't stop at the bedside, but recognizing that the whole person needed help. That would give you another opportunity to raise your voice against racism in the way that Dr. Morris's hospital has, so that it's not just 2 physicians, 2 researchers who are being attacked. Get in the line of fire. Get in the argument, get in the conversation, get in the discussion, so that it's not a few of us that are outliers arguing for civil rights and anti-racism and justice as a matter of health equity. That's what I would ask everyone to do.
Thank you so much, Professor. We'll go in the order of presentation. Professor Alston, if you're still on.
so much. Struck me about Dean Matthew's presentation is just how of the legal framework has changed. And I agree with you, Dr. Mensa. I kind of wish all over again. I also had a but quickly, and then I'll go to the quote unquote recommendation. There's a really nice economist, Alberto Alaskan, Ed Glazer, who's the current chair of the economics department at Harvard. It's a Brookings paper from the 1990s. Why the United States does not have a European-style welfare state. It's its roots, racial, and be it the immigrant, somebody that has a different skin color. And this has really been, it's been at the heart of states' rights, and it's been always this difficulty having the of a robust, not on economic principles per se, but actually on the political economy, which is really telling. Again, I've been in other parts of Europe right now. I truly feel that this time of insurance is for the poor. That right now we're Medicaid and millions of people will be losing health insurance over the course of the next weeks to months. Is frightened. I think we have a lot of and preserve some of the healthcare access for the vulnerable. Thank you.
Thank you so much, Professor Alston. We'll conclude with Professor Morse, if you could offer your recommendation.
Absolutely. Couldn't agree more with Dean Matthew and Professor Alston. Definitely agree with that call to action to get in the conversation, get to the table. And I would also say, I would encourage everyone to do two things. First is read about public health critical race praxis. It is a framework for research and anti-racist research and action that was developed and published by Dr. Chandra Ford and Dr. Collins Ironbua. It is a phenomenal framework to consider as you are trying to get your institution, your organization, your community to do things differently, to rejigger the gears so that the pattern that is produced is not racist, but is anti-racist, right? Is reparative. It leads to racial justice. So that framework is phenomenal. And then the second thing I would ask of everyone is to really step up in your institution. As Professor Alston was just describing, we are in a time of backsliding, quite frankly. And the social supports that have been possible in this country over the past 3 years are rapidly eroding. And we're going back to the incredibly inequitable access to healthcare, health insurance, and other social services that existed before some of the protections during COVID. And so I would say this is the most important time possible that you could get activated in your organization and institution to push for protections to continue, particularly those that protect marginalized communities like Black, Indigenous, and people of color communities.
Thank you so much for those recommendations. And thank you so much to our esteemed panel for your in-depth and energized presentations. Thank you to all of you for attending this seminar. It was amazing. I learned so much. The next seminar in this mini-series will be May 11th, and we'll focus on the crisis in primary care in the United States. Please look out for on the Lancet webinar hub page for more information coming soon. And again, thank you so much to each of our panelists and the audience for engaging with this. And let's get active. Let's really start making the change that we believe in. Thank you.